Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Amjad Iqbal Khan from Lahore, Pakistan for the free ultrasound webinar on ABC of carotid Doppler ultrasound. The lecture is being on air from the platform of Afro-Asian Institute of Medical Sciences and Al-Razi Institute. And the presenter of today's talk will be our renowned professor, respected Dr. Professor Nawaz Anjum Saab, who is MD, Diplomate American Board of Radiology, FCPS, and a living legend. Any questions for regarding this lecture, please write on the chat and that will be answered after the lecture. Thank you. And Sir Professor Nawaz Anjum Saab, I hand over the mic to you for your kind presentation. Thank you very much.
Thank you, Dr. Saab. Bismillahirrahmanirrahim. I welcome everybody to this lecture from City of Gardens, Lahore, Pakistan. Subhanak la ilma lana illa ma 'allamtana innaka antal alimul hakim.
Sorry for the interruption, sir. Kindly turn on your camera.
This lecture, short introduction of the color and spectral Doppler. This is a probe and this is the beam mode. And this is the beam. For beam mode scanning, 90 degrees is the best angle. Whereas when we are doing Doppler, this is the beam, this is the vessel, and 0 degree is the best angle for these Doppler images. But to avoid error, we should keep the angle below 60 degrees. As the angle increases, the Doppler shift decreases at 30, 45, 90. So the angle is increasing and shift is decreasing. So we should keep our angle below 90 degrees. I'll show you why. This is a vessel and these are the vessel walls. And these two lines, they are our sample volume. They should be kept about 60% of the lumen of the vessel to avoid artifacts from vessel walls. And this green line here is the sample where the sample is taken, and it's called angle bar also. This bar should be parallel to the walls of the vessel or in the course of the flow of the blood, this green line. As you can see here, when the angle of incidence is low, the velocity error is only 10%. When the angle goes to 70%, the velocity error is 60%. So most important thing in the carotid Doppler is the proper angle of insonation. As you can see from here, at 60 degree, 109 and 28, systolic and diastolic. We increase the angle to 70, 147 and 40, same vessel. Then we go to the 80 degrees, 290 and 78. And here we can see it's almost 3 times velocity and there's a lot of error. So keep it at 60 degrees, around 60 or 50, 45. And when the color is red, it means the blood is flowing towards the probe. It's not arterial. And the spectrum is above the baseline. The yellow is the baseline. When the flow is away from the probe, the color is blue. It's not venous color, as in the anatomy books, in the pictures. And the spectrum is below the baseline. And to sum up the Doppler, this is a probe and this is a beam. This is our baseline. Away from the probe is blue and spectrum is below the baseline. This is towards the probe, the color is red and the spectrum is above the baseline. So that's the summary of the Doppler shift and the spectral Doppler. And when you sit at the machine, the first thing you should look is at this color bar. The default setting is red is above and blue is below. If it is reverse, somebody has pushed the button, the color Doppler shift, reverse it, then you may mistake that you may be saying it's away from the probe while it may be towards the probe. So the color bar must be looked at before you start anything. And here you can see superficial femoral artery appears blue because the blood is going away from the probe. And here it is red, this is the vein because the blood is going toward the probe. Now, when you are taking spectrum, I have put a big cross here. Never ever measure the velocities or spectrum in the cross section. It should be always in the longitudinal section as here. After that, some people they are using color Doppler, but the power Doppler is the best thing to use because it is not too much color dependent. First you do the gray, you do the power Doppler. Blood flow dynamics. This stream after the rainfall in a race course, golf course, the fastest velocities are in the middle. Slower velocity due to this grass and other things, impediments, they are slower. The faster velocities are in the middle and the slow. And this thing here, water in the puddles has no flow, it's just standing there. So when you take a spectrum, these will be the faster velocities, these will be the slower velocities, and if there's any extravasation of blood or hematoma, it will not show any Doppler shift. It will be static. There will be no Doppler shift. So faster velocities in the middle, slower velocities here. This is called a laminar flow or bullet flow. And this diagram I have drawn for you, this is the baseline, this is the time, and this is the velocities. And this is the spectrum. The slower velocities are along the lower side of the spectrum, and the higher velocities are here. And this red arrow shows the range of velocities. Suppose here it is 30 and here is 90. So between 30 and 90, all the velocities are displayed in this area. So I've seen many people giving lecture. They say that from here to here is the spectral broadening. Whereas spectral broadening is here. Range of velocities increases. As you can see here is normal. At the site of stenosis, there is increase in the spectral width, and this window is narrow now. Immediately after stenosis, there is reversal of flow. This is called turbulence or eddy currents here. And again, here it is a normal flow. So spectral broadening, turbulence, and as the stenosis increases, the velocity increase, as I've shown it here. Equipment which we are using is color Doppler machines of various qualities and varieties. When you buy a color Doppler machine along with a grayscale, try to purchase with 3 active ports because you don't have to unplug this one probe and put it here and put the other one here. So buy with the 3 active ports. And this is a high frequency transducer which I'm using, 7 to 11 megahertz. And when there's infection in the patient or some skin problems, cover the probe. And in the people with the thick neck, we are using convex probe, but the image resolution is not as good as in the linear high frequency probe. Technique, most labs I've seen in America and other places, the operator sits on the head side of the patient. But the radiology departments, they always use the stool on the right side of the patient, like we are doing abdominal scanning or chest scanning or thyroid scanning. So the patient lies like this. There's a pillow under the neck to slightly hyperextend the neck. Not too much, the patient should get tired or dizzy. Slight hyperextension. And if you dissect the thyroid away from the vessels, the medial is the carotid, common carotid, and lateral is the internal jugular vein. If you take a cross section, this is ultrasonography, this is the diagram, isthmus, trachea, thyroid, common carotid, and jugular vein. This will be handy when we come to the percentage of stenosis. Then we'll discuss this thing, that cross section of the CCA. This is the anatomy of the vertebral artery. Vertebral artery is a branch of the subclavian artery, and it passes through the neural foramina in the transfer processes of the upper 6 cervical vertebrae. It doesn't pass through the C7. So you can scan it, but bits and pieces. There'll be acoustic shadowing, then artery, then acoustic shadowing. And not only the artery is running through these foramina, the vertebral vein is also running through it. And they'll form basilar artery when it goes to the area of the foramen magnum. Aims and objectives. First of all, vertebral artery evaluation. And neck Doppler, hypertension, diabetes, stroke, family history of stroke, and coronary artery disease. Vertigo, hyperlipidemia, trauma, tumors, and congenital anomalies. Vertebral artery presence or absence of flow, that we have to record. And direction of flow. Is it toward the head or away from the head? And stenosis at the origin. Now, both vertebral arteries should have a flow towards the head. If one is toward the head and the other is away from the head, that indicates subclavian steal syndrome. That is abnormal. So as you can see here, this is the image of vertebral artery. This is the acoustic shadowing from the transfer process through which these vessels are passing. Now, if you are experienced, you can guess which is artery, which is the vein. But otherwise, you have to use spectral Doppler to tell which is artery and which is the vein. This is the vertebral artery, and this is the vertebral vein. So from the spectrum, you can tell which one is artery and which one is the vein. Now we come to the carotid Doppler. These are the things you have to evaluate: IMT, intima media thickness, plaque morphology, ICA CCA ratio, percentage of stenosis by diameter, and percentage of stenosis by cross-sectional, stents, and endarterectomy. Plaques, stenosis, stenting, all these we have to look at. Now this is a grayscale image showing the vessel and intima and media. We should not include the adventitia in our measurement. This is a intima and media, and it can be measured anywhere, but mostly we measure it in the CCA. That's the measurement, and we take 3 measurements, and we call it mean intima media thickness at 3 different locations. Like here we have taken 3 measurements and it's 0.8 millimeters. And we should measure along the posterior wall. This is my practice and it is advisable. Anterior wall may not be that clear due to artifacts or aberration artifacts. So you have to use the posterior wall. And normal IMT is 0.8 millimeters. It should not be more than that. If it is more than that, it is usually associated with coronary artery disease. Then we go to the gray scale, looking at the vessels, at the bulb, at the bifurcation. The ICA is bigger and posterior toward the ear, and ECA is smaller, and usually you see 1 or 2 branches also. ICA has no extracranial branches. That's one clue also. Then we go to the color Doppler. You can see the filling, and the technique should be adjusted that the vessel should be filled with color, intima media should be visible, and there should be no color bleed. No color is seen outside the vessel. And here you can see grayscale, bulb, ICA, ECA, and here's the branch. That gives the clue. You can also recognize from the spectrum ICA and CCA. This is a CCA, bulb, and ICA. This is called temporal tap. If in front of the ear you tap and you take the spectrum from the external carotid, there'll be slight notching. This is normal and this is after tapping. So in the early stages of your training, you may be confused which one is ICA and CCA. So this is one trick that you can use. Temporal tap. Otherwise, if you are experienced, you can see simply the spectrum of this one is not as sharp peak. There's more diastolic flow. Here there's a sharp peak in the ICA and less diastolic flow. Sometime maybe very little flow, or sometime maybe reversal also. Now plaque evaluation. The plaques, they form opposite the divider. When we are going, the blood hits here, it goes around this like this and hits here. So this is the area which is vulnerable to trauma, repeated trauma from the turbulent blood, and here where the plaques are formed. Like here, and some plaques may show hemorrhage inside. These are dangerous plaques because they can rupture and cause embolism to the brain. And here you can see this is a divider and this is a plaque. This is the ECA, as you can see a branch here. Here, mixed density plaques. There can be calcified plaques like this one, and they'll give you acoustic shadowing. Now, this is a dangerous plaque from our point of view, because when it is anterior plaque, you'll see acoustic shadowing. Now, you cannot tell how much stenosis is there posterior to this one. Try to see from different angles, but this is a nightmare. This is difficult to evaluate this area. This is ulcerated plaque. These are also dangerous. Calcified, they are not as dangerous because they don't usually embolize. But ulcerated and hemorrhagic plaques, they are dangerous because they can produce emboli. Spectral analysis. This is a sketch of the CCA and bulb. The samples should be taken 5 centimeters away from the divider, because here there is usually turbulence due to wide bulb. It should be taken 5 centimeters away. And in the ICA, if there is stenosis, take sample at the site of the stenosis. Otherwise, as distal as possible. Now, the blood is coming from the heart, so our proximal is the heart, and towards the head is distal now. It's not proximal because we are coming from the heart toward the brain. Site of measurement, angle corrected velocities, and it should be kept below 60 degrees. And if you keep it constantly, same technique, the velocities and steadies can be measured in other countries and other cities and can be compared. ICA-CCA ratio. You take peak systolic velocity and take end diastolic velocity in the CCA. This is a CCA. This CCA, left CCA, left ICA. So you take these velocities, IC and CCA, the velocities. And after that, you take ICA peak systolic velocity here, ICA and diastolic velocity here. Then systolic velocity ratio and diastolic velocity ratio. And if you can see up to 60%, there's no disturbance in velocities and there's no disturbance in the ratios. But above 60%, there is increase in the velocity, systolic, diastolic, and the ratios are increased. So for early stenosis, you cannot rely on ICA-CCA ratios, systolic and diastolic ratios. You have to use some other means to measure them and report it. Now, percentage of stenosis is by diameter. This is the vessel. This is a plaque. This is the total diameter. And this is the patent diameter. So you give the machine these two readings, and the machine will calculate the percentage of stenosis for you. You don't do any calculations or calculator. Here you can, there's the total lumen. You can see the plaques here. And you can see the patent lumen. From here, you can calculate the percentage of stenosis, as in this case, it is 74.6%. But this method is not very accurate. It gives you good idea about the stenosis, but the best area is to calculate by percentage of stenosis area. This is the image I've shown you already, that you take a cross section of the vessel. This is the internal jugular, and this is the common carotid. This is our vessel cross section, which is called area A. And this is the patent lumen, which is called area B. So you give the machine these two readings, and the machine is going to calculate the percentage of stenosis based on area of cross section. This is more accurate than the ICA CCA ratio and the diameter percentage. Like here, first the total lumen, then the patent lumen, 60.5%. Now we come to the plaques here, and most people, they are doing it stenting or angioplasty. Some people are doing endarterectomy. So that's the angioplasty being done. And these are the stents. Stent was a person, it's the name of a person, stent. It's not the device. Device has been named like volt and watt. They are all names of the people who named them. The stent looks like on gray scale. And here the stent has been placed in this vessel, and you can see the stent. And here you can see the patency of the stent. You can evaluate. Usually they remain patent, but sometimes due to some blood diseases, and depending on person to person, it can stenose or even can get occluded. Endarterectomy operation is done, the plaque is removed, is sutured, and sometimes they put a plaque, this stent there, or otherwise they close it. And this is after endarterectomy, intraoperative sonogram. So extracranial vessels are only, these are the limitation of neck vessel Doppler. Only extracranial is evaluated. 20% difference on both sides. CCA 35 centimeter per second, above 135 hypertension. If the velocities are very high, you should think of hypertension. Below 35, poor ejection fraction. These are the indirect result. You can see diagnosing hypertension and also poor ejection fraction. Conclusion: the carotid Doppler ultrasound is highly accurate, but it is operator dependent. About 200 exams should be done to be familiar with technique and anatomy. Even more exams are required to interpret. Thank you very much.
Jazakallah, sir. It's a very wonderful talk, especially for the beginners, and what to look at longitudinal and cross-sectional scans. Even it was very informative, not only for beginners, but also the ones who are doing. Questions? I don't think there is any question. Perhaps everybody has understood your lecture very deeply and no questions has been asked.
Thank you very much. I enjoyed talking to you, and I'm happy that you invited me for this lecture.
Sir,
And I
it's
hope to
always
give
a
in
pleasure,
future
sir.
programs.
Inshallah, sir. It's always a pleasure to have you with us and listen to you whilst you are sharing your knowledge in a very, very effective way, in a style that everybody will understand. Sir, thank you very much. Perhaps there is one question.
Thank you.
Sir, there is one question.
Yes.
After all, there is one question. Sir, there are limitations of this exam. Any limitations?
Limitations are if the patient is not cooperative. Moving, because Doppler is sensitive to movement. other is very thick neck and short neck. These are the limitation. Otherwise, I don't think there's any other limitation.
So that's good, sir. Questions have started coming. Another question is, sir, kindly tell about CCA in diabetic patients.
Any disease like hypertension and diabetes will lead to atherosclerosis. So we have to look at the intima media thickness in these patients. They will also have coronary artery disease, and gradually they'll build up cholesterol. If there is hyperlipidemia, then this intima media thickness will increase, and finally there'll be plaque formation.
Sir, next question is, what is the significance of TA maximum in carotid Doppler?
I don't understand.
TAV. I don't know.
Systolic increased systolic velocity.
G.
That I mentioned that if it is very high, you should suspect stenosis proximal, and if there's no stenosis, then hypertension.
Hypertension. Sir, thank you very much for your talk and explanations to the people's question. Jazakallah, sir. Jazakallah.
Thank you very much.
Okay.
Thank you,
Thank you very
everybody all over the world.
Thank you all the participants,
Allah.
and we finish our talk today's session over here. Till we join again, thank you very much. Allah Hafiz.